Hi guys, welcome to your first remote Ther Ex lecture. Welcome to my makeshift home office here. I can say I am digging this dress code though, but in all seriousness, we'll get started here. Chapter 1 and 2 are combined together in this lecture, so we'll go through this and then there'll be some discussion board questions posted for you for this as well. So what we're starting to talk about is just some foundational concepts, and there's a lot of terminology in these first few chapters that you just want to be familiar with. So with therapeutic exercise, what we're talking about is systematic planned performance of bodily movements. You guys can read all this. The main thing is with therapeutic exercise that we're trying to either address or prevent any impairments with our patient and really trying to restore or improve their physical function. The basis for everyone's therapy program should be rooted in therapeutic exercise. It is great for them to come in and get modalities and come see us to get feeling better, but we need to be able to teach them exercises so that they can continue with their program on their own. With insurance companies limiting the amount of time that we get to see patients, it's really important that they're able to learn and perform a good, solid exercise program, because that's something that they can continue to do even when they're no longer being treated by us formally. We may also prescribe exercises to reduce some health-related risk factors, and again, really just to overall optimize the health of our patients. When we look at physical function, we're looking at a lot of things. We're looking at flexibility, which we could all probably work on a little bit. We're looking at a person's mobility. How are they able to get around? And this is something that we can kind of gauge even from day one, bringing the person back to be evaluated. How are they walking? Do they appear to be in pain? Are they using any devices to get around? Looking at their coordination too. You guys are going to talk a lot more about this, as well as the neuromuscular control that is listed next in your neuro class. But there's going to be some overlapping carryover into this class as well. But looking at coordination, neuromuscular control, those are things that are often affected by disorders of the nervous system. Balance. We're going to have a whole section devoted to balance later, and I know you guys have talked a little bit about it before. A lot of times we think about our elderly population and having balance issues and being fall risks, and that is absolutely important. But we also look at that with our younger athletes as well. After injury, balance is definitely one thing that's affected and that we can train and can actually get better pretty quickly. Muscle performance, you guys have done manual muscle testing, and so that will be a recurring theme in here as well. Cardiopulmonary fitness, we again have a whole lesson on this closer to the end of the term, looking at aerobic capacity and things like that. Looking at assessing patients' posture, I'm pretty sure you guys covered some of that in kinese. And then stability kind of goes in with all of this stuff as well. So what would be some examples of therapeutic interventions? Oh, let's go back because there isn't a slide that answers all that. So normally in class, I'd have you throw out some answers. Normally in class, you guys would have also completed your 2-week internships by this point. So we are going to kind of just, again, we're going to roll with the punches here because this is what we do. But some examples of therapeutic interventions would be things like aerobic conditioning. A lot of times we don't do a ton of this unless we're in specifically like cardiac rehab, but even having our patients do an aerobic warm-up, we do need to be taking into consideration their aerobic capacity and how they are going to respond to aerobic exercise, especially if they have any underlying health conditions. Looking at muscle performance, we're going to look at strength, power, endurance, stretching, flexibility, neuromuscular control, postural control, balance, and then anything task specific. So that whole list that we had on the previous slide, those are some of the things that we're going to use to incorporate into a patient's exercise program. We do want to make sure that our patients are going to be safe when they exercise. So again, knowing a little bit about a patient's past medical history, this is something that usually is taken in by the PT during the initial evaluation. Sometimes we don't always take it into account maybe as often as we should or as seriously as we should, but do know if your patient has any cardiac history, pulmonary issues, just kind of what's their overall health status so we know and can sort of gauge how they should respond to exercises. Think about the environment in which they're going to be exercising when they're with us in therapy. They should hopefully be supervised by a professional. They're being given criticism and tips on their form and their performance of exercise. So think about where they're going to be exercising once they leave the safety of the physical therapy clinic. Will they be going to a gym? Will they be exercising at home? What sort of equipment are they going to have access to? So you can adjust your program accordingly for that. Even in your gym, think about what space, the support surface that they're on. One of the things that probably gives me the most heart attacks in gyms is watching elderly patients get up and down off of upright bikes. So just, again, think about patient safety. As far as accuracy and using proper form, this is, again, one of our biggest jobs, and this is why we are paid or reimbursed to actually work with our patients, to make sure that we're actually watching them perform their exercises and that we're giving them feedback, whether that's tactile cues, verbal cues, whatever we need to do in order to make sure that they're performing that exercise properly, because if they're not, they're probably not targeting the muscle group that we're intending for them to target, and then that's not really addressing the issues that we're intending to address. So make sure that your patient is using good form with their exercises. And if they're not, it's absolutely your job to step in and say, no, you're not doing this right. This is what you need to do. As I mentioned earlier, think about too where they're going to transition after they're finished with therapy. Are they going to be going to the home, to the gym? So again, make sure they're pretty solid on their exercises by the time they get there. And for you guys as the therapists, make sure that you're using good, proper body mechanics. This is a physically demanding job, and we want you to be able to do this for many, many years to come. So make sure that you're being safe when you're helping your patients as well. So I know you guys have gone over the disablement model, and I know this because I'm just talking about it in the procedures class as well. But the original model that we followed was Nagy's model, where we had the active pathology, impairment, functional limitation, and then disability. The ICIDH came out with a newer model, and it's really actually pretty similar. They just called it a little bit different things, and that stands for the International Classification of Impairments, Disabilities, and Handicaps. You can look that up in your book. It's on page 5 in chapter 1. And it was through this chart that we've kind of adopted the one that we are using more commonly now. So the new disablement model, the one that's been accepted by the APTA, was proposed by the ICF, which is the International Classification of Functioning, Disability, and Health, and it's based on a more broad view. It has 2 major parts, and actually the majority of it is the same as the Nagy model. So part 1 is looking at the actual functioning and disability of the person, looking at the body functions, body structures. The body structures would be the same thing as pathology. The body functions would be the same thing as impairment. Functional is functional limitations, and disability is disability. So really part 1 is the Nagy model. Where this is much different, or not, where this is, I guess, a little different than the Nagy model, is the part 2. And what this model takes into consideration is that there are other, sometimes outside outlying factors that can play into part 1 or into the Nagy model. And those are things like environmental factors. Where is the person working, exercising? What sort of environment are they functioning in? And then personal factors, which are things like their age, their gender, their motivation levels. I'm sure you can all attest to someone who is highly motivated is going to perform one way in therapy, where someone who is lacking motivation is going to probably perform another way. So those things can absolutely play into how those things affect a patient as well, how an injury can affect a patient. So again, the impairments in body function are things, just like we talked about before, the functional limitations, things that the patient is unable to do, which kind of goes along with activity limitations. So being unable to do certain actions or tasks, activities. which may then lead to participation restrictions as well, which was kind of the old disability, not being able to participate in things that they want to be able to do. And again, those contextual factors, some outliers that may affect how a person performs, those environmental and those personal factors as well. So here's how this is sort of visualized. It's not really a linear process like we sort of talked about a lot with the Nagy model, where pathology can lead to an impairment, which can lead to a functional limitation, which can lead to a disability. These things kind of all act together. So your health condition at the top, that is the disorder, the disease, the medical diagnosis that the patient comes in with. That may cause impairments, which may or may not cause limitations in their activities, which may or may not cause participation restrictions. So again, all of those things kind of work on a continuum, and it's not necessarily this builds on this all the time. And again, then down at the bottom go your environmental and your personal factors, which also filter their way back up and can have an effect on any one of those levels as well. So again, as far as how this has an effect on Ther Ex, it's again being able to understand the person as an individual and what's going on with them, and then tailoring an exercise program to meet their particular needs. This is one big thing I cannot stress enough in this class, and you're probably going to get sick of hearing me say it. But I think we see a lot in the clinic, people kind of get into sort of a rut, and you see a patient with a knee disorder, whether it be a knee replacement or an ACL reconstruction or a sprain or a strain or something, and it's just like, okay, well, here's the knee exercises that I know, so here's what you're going to do. And not all knee programs should look the same, right? We need to know more about the person. Again, environmental factors, personal factors, motivational factors, exactly where they are on this disablement process, right? And sort of tailor their exercise program exactly for them. So again, one of my big pet peeves, exercise programs should be individualized for your patients, not just based on what their diagnosis is. Impairments we've talked a lot about before, but these are sort of the consequences of those pathological conditions. So say the person has a rotator cuff tear, the impairments would be the things like the decrease in range of motion, decrease in strength, decrease in flexibility of the shoulder. And it can affect all of your systems, your musculoskeletal, neuromuscular, cardiovascular, and tegumentary. And so again, there's going to be overlap here between the different systems. There's not often something that doesn't have an effect somewhere else. And so we, again, need to take a look at the whole person, the whole picture, and then tailor an exercise program to fit their needs. Again, we can manage most of these things with exercise. You're probably going to hear this a lot from me as well, but I am a huge proponent of exercise. Exercise can fix a lot of what's wrong with a lot of people. And people just don't do it as often as they should. But as far as sort of breaking it down into the systems, looking at the musculoskeletal system, exercise can improve all of these things: pain, muscle weakness or muscle limited endurance, decreased range of motion, restrictions in joint movement, decreased muscle length, which plays into flexibility, joint hypermobility, faulty posture. In the cardiovascular and pulmonary systems, someone who has decreased aerobic capacity, we can assist with that with exercise. Exercise can help with circulation, again, help to decrease pain. Pain is on every single one of these lists. Fun tidbit, I'll probably repeat this too, and I apologize for that, but I went to a continuing ed course not too long ago, and it was about arthritis, and one of the speakers there was on the board of directors of the College of Rheumatology, so I think she pretty much knew what she was talking about, but they have done lots and lots of studies, and they've actually found that doing just a little bit of exercise, and what they were looking at was just leisurely walking, was as effective as taking over-the-counter pain medications for patients with arthritis. So pain can absolutely assist or be helped by exercise, even though people in pain don't necessarily always think, hey, I should probably go exercise, right? So it's our job to educate them that it's okay as long, as we follow certain guidelines. Sorry, got off topic. Back on neuromuscular. So also things like impaired balance, incoordination, abnormal tone, movement strategies, things like that. We can address all of those things with exercise. And as far as integumentary goes, talking about scar adherence, we've talked about using cross-friction massage and things like that, but just using exercise to restore flexibility and help getting that area moving will hopefully prevent scars from adhering down in the first place. Again, impairments are going to come from underlying causes. It's our job to try to figure out what that underlying cause is and then be able to address that. But do keep in mind that impairments can appear differently in different patients, and we just kind of touched on that. Again, not all impairments are going to lead to functional limitations. They're not all going to lead to disabilities, and environmental factors and personal factors can play into that as well. Again, our goal is to try to improve function as much as we possibly can. And really, if you look at this from a patient standpoint, how they're going to determine whether or not PT is successful for them is, are they getting better and are they seeing improved function? So it's really, really rooted in function. And I know you've heard this a lot, function, 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 right? But that's how patients are going to gauge whether or not they're actually getting better. Or am I able to do these things in which I was limited before? So again, functional limitations are going to occur at the level of the whole person. They are the result of impairments. And again, it's the inability for the patient to do some sort of activity in the typically expected manner that they would normally do that. So some functional limitations, and this list could go on forever and ever and ever, but things like reaching, lifting, bending, getting in and out of bed, standing up, sitting down, going up and down stairs, walking, again, anything. There is a whole big list in your book, and you can take a look at that if you want to, but I'm sure you could think up of at least 20 functional limitations real quick from the top of your head. And then finally, disability. Again, the inability to perform or participate in activities or tasks related to oneself, home, work, recreation, or the community in a way that sort of defines or the person perceives as normal. So again, things like self-care, getting around the community, home management, work, school, whatever it is. And again, you can look in the book if you want to see some more examples of that. But again, this is kind of the most severe level of involvement. So we've talked about these types of things before, but here's just a case study to run through some of the examples of this. But let's say we have a 26-year-old baseball pitcher who has shoulder pain. He's been diagnosed with rotator cuff impingement. He's unable to lift his arm overhead without pain. He's also unable to put on a coat without pain. He's no longer able to pitch or play baseball because of pain. So think about, what would the pathology, impairments, activity limitations, and disability be? And I'm actually just going to save that and use it for your discussion board. So if you want to see the answers, check out there. Some risk factors, some things that can predispose a person to a disability. There are some biological factors that play into this, things like a patient's age, their weight, their family history, congenital abnormalities, things like that. Their behavioral, psychological, lifestyle type choices, so whether they're more sedentary or active, their tobacco and alcohol use, how their nutrition choices they make, and their motivation and coping skills play into that. Their physical environment, are there any architectural barriers that they need to overcome on a daily basis, or even just the ergonomics of their workplace? Is their work set up the way that it should be to try to minimize any chance of injury? Socioeconomic factors also play into how a person is going to sort of respond to or react to a disability. And these are things like money and access to healthcare and education and family support. Things like that all play into how a person's going to perform in therapy and how they're going to respond to disease and illnesses. So again, just to kind of bring things all together, we do need to understand the different levels of the disablement model, the pathology, and what effects that might have as far as impairments, functional limitations, and disability goes. And again, we do want to be able to design an exercise program individual for each one of our patients. Evidence-based practice is another term that you'll probably hear thrown around a lot. And this is one of the reasons that we do push research a little bit on you guys, make you guys read some scientific journal articles and things like that. And the reason is that we just want you to actually make some informed clinical decisions when it comes to choosing exercises and things like that for your patient. Like I said, you see a lot in the clinic, patients doing the same thing kind of over and over and over again, and many patients doing the same different things. But again, we should be looking to the research and looking for evidence to do what we're actually doing. Like when we looked at research articles and modalities, should we be using some of these modalities on our patients? Is there actually research to back up that these are good choices to use for our patients? So again, identifying the patient's problem, being able to scan the literature and try to find anything that would pertain to this patient's problem, analyzing that evidence to determine, does this really pertain to my patient or not? And then think about, can I add this feasibly into their clinical experience? So again, if possible, if it appears that, yes, this is a good intervention to use with my patients, try to add it into their program. Then we always want to assess our outcomes to determine whether or not this is working, right? We talk about this as far as the assessment portion of your note all the time. How did the patient respond to therapy? Are they showing signs of improvement? If they are, great, keep rolling with it. If they're not, let's switch gears and change something up and try to find a way for them to respond in a more beneficial way. You guys have also seen the patient management model before, so again, I'm not going to go too far into this, but just as a quick review, remember the major components of the patient-client management model, which is examination, evaluation, diagnosis, and prognosis. All of those are taken care of by the PT during the initial evaluation, and then interventions are when the patient comes back and the PT, PTA work together to help the patient reach their goals. Again, this is going to be seen by functional outcomes for your patient. That's how they're going to be determining whether or not they're doing well in therapy. So motor learning. So you guys will talk a decent amount about motor learning in neuro. And so I'm not going to get into all the nitty-gritty details here, but I am going to talk to you about it from a therapeutic exercise standpoint and in teaching your patients how to properly perform a therapeutic exercise program. So looking at different types of motor tasks, there's discrete, serial, and continuous. A discrete task has a distinct beginning and an end point. You're going to do one of these. The example is a push-up. Serial tasks are things that involve multiple steps put together, like eating with a fork. A continuous task is something more repetitive, like running, biking, elliptical, doing any type. Usually that's kind of our warm-up. So think about what sort of task are you training your patient in? And then there might be a better way or a good way to do that. Also, some things to think about as we progress motor tasks. There's a whole chart in your book about this, and it's on page 29, I believe. So definitely take a look at this chart, and I think there it is. It's on the next slide as well, so you can see what we're talking about there, and we'll go through an example once we sort of go through the basics here. But looking at motor tasks, there's 4 major domains or sort of categories that your book breaks it down into. So looking at, is the person performing this task in a closed or an open environment? In a closed environment, nothing around the patient is moving. In an open environment, objects or other people or maybe even the support surface are going to be in motion. Is there going to be intertrial variability in the environment, whether or not that's absent or present? So if it's absent, the environment is unchanging. If there is intertrial variability, that means that the environmental conditions are going to be changing each time that the person attempts this motor task. Next is body stable or body transport. Body stable means that the patient is going to be stationary. Transport means that they're moving or it's a dynamic task. And then whether or not they're manipulating objects, either absent or present. So if it's absent, there's no upper extremity manipulation of objects. If it is present, then their upper extremities are handling objects. So taking a look at the actual chart and going through an example, let's take this one because I think we probably all like to do this right now. So second column over, very bottom, drinking a cocktail on the deck of a cruise ship. Doesn't that sound delightful? So if we look at the 4 domains and where that would fall, that is considered to be an open environment because the cruise ship is going to be moving, right? The support surface is not still, which also then lends to intertrial variability. So there can be differences each time the person takes a sip of their cocktail. The ship could be moving a little bit, so there could be variability each time that the person takes a drink. Their body is stable. They are just standing still, so the person themselves is not actually moving. And there is upper extremity manipulation in that they're holding on to their cocktail. So let's take one more. Let's go up here a little bit. Carrying a tray of food or drinks from the kitchen to the living room using different trays and routes each time. So this is the last column, second row down. So with that particular situation, that is going to be a closed environment. The ground surface is not moving or changing. There is going to be intertrial variability because you're taking a different route each time. We are now doing body transport. We're walking, we're moving, we're dynamic. And there is upper extremity manipulation. Again, we're carrying a tray with food and drink, so we need to keep that balanced. So definitely familiarize yourself with this chart, sort of understand what these different examples mean. And if you have any questions, let me know. As far as the stages of motor learning, there's the cognitive, the associative, and the autonomous stages. And again, in neuro, you'll go over these because after neurologic disorders or insults, oftentimes a person will regress and sort of have to learn how to do new motor tasks again. With that being said, sometimes we're prescribing exercises to patients who have never exercised before, and so this is learning a whole new set of motor tasks. So typically we start in the cognitive stage. This is where the patient's actually learning what they need to do. We can use some mental preparation. There are actually some studies, and we'll talk about this a little bit later in the term, that sort of visualization, mental rehearsal, things like that have actually been shown to be beneficial for patients learning new tasks. Then we move into the associative stage. The patient is starting to get the hang of things. They make more infrequent errors, so you don't need to correct them as often. They're starting to sort of fine-tune what they're doing. Their timing is improved. They can oftentimes self-correct errors. They realize when they're doing something wrong, and they can usually fix it. And then where we sort of hope to get is to the autonomous stage, where the patient's able to independently perform a task. And maybe even doing others at the same time, so possibly even multitasking. But these are things like walking. All of us, I'm sure, we're in the autonomous stage for that. We can just go. We don't have to think about, okay, left foot, right foot, heel strike down now. Okay, let's move this, swing through here, because it's automatic for us. But again, after an injury or things like that, things might not be so automatic anymore. So again, those are your typical stages for motor learning. When our patients perform practice, we can look at doing part versus whole practice. Sometimes, which is exactly what it sounds like. Part practice is just doing a piece of the task and doing it repetitively until that starts to become second nature, versus whole practice, which is doing the whole task in a sequence. Again, depending on what task you're doing, one might be a little bit more beneficial than the other, or sort of where you are. Sometimes, again, it's easier to start with just doing a part of the skill because doing the whole thing would be a little bit overwhelming. So again, just sort of think about what skill you're doing and where your patient falls, how they're able to respond to that. We can also look at practice order. We can have a blocked order where we give them sort of individual tasks to do in a certain predictable order. This usually results in a rapid improvement of their skills. We can also do things more randomly, where they do this task, then another task, then another task, and it's not necessarily in a sequential order. This helps with skill retention. We can also do a combination of both, but again, make sure your patient's sort of at that point. If you do that too early, they may just tend to get frustrated with that. And then I had mentioned just a minute ago about the physical versus mental practice. Again, physical is what we're going to be doing with them. That's best for functional training. But again, they have done some recent studies that found that mental rehearsal or visualization prior to performing physical tasks may actually enhance the results for some patients. Feedback, how we give our patients feedback. Intrinsic versus extrinsic. Intrinsic are sort of sensory cues from within the learner. It's sort of hard to gauge this sometimes with our patient. Extrinsic is typically feedback from the outside, which would be from us, the therapist. There is knowledge of performance, which is KP, and knowledge of results, which is KR. Knowledge of performance is either during or immediately after the task, which tells them about the quality or how they did while they were doing that task or that exercise. Knowledge of results is usually right after, and it's just about the outcome, maybe not necessarily about how they performed it, but just sort of did they get to the end point or not. As far as feedback schedules go, we can look at concurrent versus post-response, meaning do we give them feedback during the task or do we wait until the end and tell them how they did? Is it immediate, delayed, or do we give them summary performance? And then variable versus constant. Do we give it to them sometimes but not all the time, or do we constantly give them feedback? Again, depending on where they are in the program, in the beginning they might need more constant feedback, more immediate response, but as they start to get the hang of things, they will probably hopefully need feedback less and less. So again, with patient education, and the reason that we've talked about all of these learning styles is because we need the patient to be an active participant in their own recovery. And by teaching them exercises and things that they can do outside the walls of physical therapy, they do become more of a participant in their own functioning. It gives them sort of their own or some responsibility in their own functional outcomes. So it's not just, well, I'm going to therapy and they're going to fix me and make me all better. I'm going to therapy and they're going to teach me ways that I can do exercises and I can be better and get myself better. Again, if the patient understands their goals, it's going to be more meaningful. So gathering that information from your patient and tailoring the exercise program to those goals. And it's also really important to make those goals attainable. If the person comes in and they just feel like they're failing all the time and they're not meeting any of their goals, they tend to get very frustrated and that tends to tank their motivation. So we want to make sure that we're setting little goals and that the person's being successful in seeing those successes. We also, again, want to make the plan applicable to the patient's lifestyle. So figuring out, again, what sort of environment are they going back to? What do they need to be able to do? And making sure that we have addressed that in our exercise programming. So the effects of, or how we can have effective exercise instruction. Things like demonstrating the proper techniques. Again, it might help if the patient sees what they're supposed to do first. Sort of figure out how the patient learns best. Do they like to see a demonstration? Do they want tactile cues? Do they need to see pictures? Do they just want an explanation? What's going to work best for them? Make sure we're giving clear and concise directions. Again, some of this could be completely new for the patient. Maybe we do need to give them written illustrations or pictures. Most clinics have some sort of program that they can use for that. Demonstrate proper form for your patient and make sure that they are using proper form when they're first learning especially. Teach exercises in small increments and don't throw everything at them at the very beginning. Again, make sure they see little successes along the way. And then again, constantly motivate the patient so that they stay motivated. We do want to make sure that we are also communicating effectively with our patient. So again, taking into account differences in age, language, cultures, and I know you guys have talked a little bit about this before, but things like eye contact, physical contact, how we greet and address a patient. Just keep all those things in mind whenever you're working with patients. Just be respectful is really all it kind of comes down to. Do keep in mind, especially around here, we do tend to see some patients with different religious beliefs and clothing restrictions. When I note a lot, women who only wear skirts or dresses can sometimes make it a little difficult. Just because they're coming to therapy doesn't mean they're going to necessarily wear pants or shorts. So that might mean we need to take them into a private treatment room to do some of their exercises, or at the very least sort of turn them on the treatment table in order to protect their modesty. So again, just little things like that to show that you have respect for their religious belief and aren't asking them to change, but are finding ways to sort of adjust your exercise program to them. It sort of goes a long way with your patients. All right, we are going to quickly go through some cognitive domains. Just again, and think about how you would do exercises, because we will work with patients in all of these domains. Infants, we're not going to spend too long with, but it is very possible that you'll work with infants, and there it's really more working with the parents. Toddlers, preschool, school age, and adolescent aged children. So again, with the infant, you're not going to instruct an infant to do anything. Try it sometime. I promise you, it's not going to happen. So this is, again, really more patient or parent interaction and parent education. So teaching them things that they can do with their baby to help. Again, anything to smile at the baby, use favorite toys to try to get them to do what you want them to do. Toddlers, you might have a little more luck, swaying them to do what you want them to. So you can use pretend activities, get imaginative, get creative. Kids' jobs are to play. So find ways to make them play, make it fun. You have to make therapy fun or there's no way they're going to participate. Preschool age, this is typically your 3 to 5 age group. You might be seeing them in their preschool, possibly at their home as well. So again, imagination, creativity is going to go a long way. Try to plan your treatment in advance, but have backup plans B, C, D, and E, because again, kids are unpredictable and they may want to do something today and it may be their favorite game in the world today, but tomorrow it's not going to be anymore. So you want to have alternatives in mind. School age, again, kids are pretty clear by this age what they like, what they don't like. So again, just try to make it fun for them. And then adolescent, speak to them on their level. We're basically dealing with mini adults at this point, so they can become more of an active participant in their goal planning and do usually respond pretty well. So just, again, treat them with respect. All right. Whew, we're doing it, guys. So chapter 2, prevention, health, and wellness. I promise you this part is much shorter than the first. So looking at health, wellness, and health promotion, and the differences there. So health is just the sort of general physical, mental, spiritual condition of the body. Wellness is maintaining a state of good health through lifestyle choices. And health promotion is just trying to promote and grow that development of health within a population. So ideally, we would love to get in and work on prevention activities with all of our patients, but that's not always the option. So primary prevention is preventing a target problem or condition in an individual or community at risk. So again, this is trying to prevent the problem from occurring in the first place. Secondary prevention is decreasing the duration or the severity of the disease. So this is kind of, I guess, like flattening the curve now, right? So it's there, it's happening, but we can decrease the duration. We can decrease the severity if we jump in with some of our knowledge as PTs and PTAs. And then tertiary is decreasing the degree of disability and promoting rehab in people with chronic or irreversible diseases. So again, we might not be able to change that underlying process, but we can find compensatory ways to do things. We can find other ways to do things. And that's where we're getting into sort of that tertiary area. So again, setting goals and objectives, identify the purpose of the program, and talk with the patient about this again. What do they want to get out of therapy? What do they want to be able to get back to? Set goals based on that, and then identify your objective or your plan as to how you're going to get there. Then comes implementation. Again, this is what we do with our patients the whole time. Again, be adaptable, be prepared for the unexpected, people coming in late, canceling appointments, changing appointment times. Things happen. They didn't get to do their exercises this week, but they normally do. So again, just be able to be a little bit flexible with your patients. And then evaluate the results. Again, patients are looking for results, and truly as therapists, we are too. We just kind of look at different things sometimes. So again, as therapists, we're going to be looking at what was measured in the initial evaluation. After a couple of weeks of therapy, are they showing signs of improvement? Is their range of motion getting better? Is their strength getting better? Their endurance getting better? Their flexibility, their function? Whatever it is that we were looking at, we need to find ways to show that they're actually improving through the course of therapy. So things like if you're conducting an exercise class, again, you can record baseline data and assess the progress till the end. like you're doing in some of your research projects, which hopefully we get to do. Ask the participants to evaluate the program and ask what could be done to possibly improve the program. Some things, again, to consider. The exercise has to be specific to the goals of the individuals. For kids, it needs to be fun, usually a set period of time. For older adults, sometimes we have to start a little bit more slowly, again, to let them see those little successes along the way. And if you're ever doing screenings, which we may do, we go out into the community and do this. Things like posture screenings. We could take handouts with some follow-up recommendations to give to the participants as well. Okay, so some issues affecting exercise adherence. Issues that could cause poor exercise adherence are things like poor or limited leadership, which really sort of boils down to the patient doesn't think you're paying attention to them. If they are coming to therapy at an inconvenient time, usually they're choosing their own appointment time, so hopefully they're picking something that's convenient to them. If they're experiencing further injury or pain, boredom with the exercise. So again, this plays into or goes along with matching the exercises to your patient, making sure you're doing things that actually challenge them and are meaningful to them. Poor individual commitment. This is speaking to their motivation levels. If they're not aware of the progress that they're making. So again, not only are we taking measurements, but let the patient know what we're measuring and let them know how they're doing in therapy. And if they have poor family support, if their family is not supportive of what they're doing, they tend to have less motivation to come to appointments and do their home exercise program and do the things that we want them to. So issues that would promote better exercise adherence, pretty much the opposite of the first list. So having effective leadership, again, feeling like they're being watched in the clinic and they're giving or getting feedback on their exercise performance. So positive reinforcement. If you can show them exercises and help make that part of their regular routine. Again, this goes into convenience. You don't want to give them a home program that's going to take them an hour to do every single night. Not many people have that kind of time. So pick the most important things that you want them to be able to do and make sure that they do those. That they are not experiencing any further injuries, that they are actually maybe even having a little bit of fun, or at least, being given a little bit of variety in their exercise program. Sometimes groups can really help with this, getting that social support from other people who may be going through some of the same things. So that's why coming into, therapy in the clinic can sometimes be a good thing. We'll start to talk to the people around them and find out what's going on and how they're doing. And that is motivational for your patients sometimes. Again, getting those regular updates on their progress and having family approval or support as well. All right, so that wraps us up for this lecture. Thanks for hanging in there with me. We'll see you on the next one.